Dear ladies and gentlemen, welcome to the video abstract with the title Atrial Fibrillation and AVNRT at the same time. Is this possible? We present a rare case of AVNRT with upper common pathway block. My name is Berg and I would like to acknowledge the other authors, which are Daniel Hofer and Adan Saguna from University Hospital of Zürich. We jump directly into the case. It is a 34-year-old male. He was referred to our hospital for an EP study due to recurrent palpitation. And as you can see on the top right, he presented with a narrow complex tachycardia with a heart rate of around 180 beats per minute. This tachycardia was successfully terminated by the administration of 18 mg adenosine, which you can see on the bottom right of the slide. An echo has shown a structural normal heart. We jump directly into the EP study. In the beginning of the EP study, we showed normal baseline intracardiac intervals. Dual AV nodal physiology was present, and VA was dissociated during ventricular stimulation. Now, on the top right, you see the narrow complex tachycardia running, induced by an atrial burst stimulation, and during the tachycardia, VA is dissociated. And on the bottom right, as you can see, we were able to induce a short sequence of precursor atrial fibrillation, which was running here during the ongoing narrow complex tachycardia. So this precursor atrial fibrillation did not influence the ongoing tachycardia, again indicating AV or VA dissociation. So which are the differential diagnoses in narrow complex tachycardia with VA dissociation? We have to consider high settle VT, which was in our case unlikely, since his signal was always leading the V signal. We have to consider AVNRT with upper common pathway block, and we also have to consider orthodromic AVRT using a nodovascular or nodoventricular fiber as the retrograde limb. Our take-home messages are: VA block during AVNRT indicates the existence of an upper common pathway, but it is difficult to differentiate AVNRT with upper common pathway block and orthodromic AVRT using a nodovascular or nodoventricular fiber. To differentiate these two, there is an important maneuver to be performed. It is His synchronous PVC. That means applying a premature ventricular stimulus during His bundle refractoriness. This maneuver could advance the next His or terminate the tachycardia if a nodovascular or nodoventricular fiber is present. In our case, we also thought of this maneuver to perform it. In our case, this was very difficult to perform and difficult to judge because we had slightly varying cycle lengths. After all, what we did was an empirical slow pathway ablation, and after the slow pathway ablation, the tachycardia was not inducible anymore, and the patient was free of any symptoms, indicating that our diagnosis in this case was AVNRT with upper common pathway block. Thank you very much.